Good morning, everyone. This is Prentice Rhodes, and I'm a product manager and a master instructor for the National Academy of Sports Medicine. And today, we have two very special guests with us. We have the lead reviewers for the recently released CES course. I have with me Kyle Stull, Dr. Kyle Stull, and Dr. Scott Cheatham. Just a brief introduction about both of our guests. Kyle Stull is a faculty instructor for NASM, and he helps us a lot with content development, teaching our workshops, which focus on fitness and corrective exercise. He's also an adjunct professor at Concordia University in exercise and sports leadership department. So we're very happy to have him as part of the organization and on with us today. And also, Kyle is a new father, so I want to take that time to say congratulations to him for everyone out there in the social media land. And we also have Dr. Scott Cheatham, who's the associate professor in the Division of Kinesiology at California State University, Dominguez Hills. He's a research consultant for many health and fitness organizations, including us here at NASM and Rock Tape, as well as other organizations. He's been published in more than 100 articles, and he also maintains a private clinical practice in Southern California. So, welcome, gentlemen. The first question I have for you is, how do both of you sleep? Because it sounds like you do a lot, you have a lot of activities going on. How do you manage all of this? Let's start with you, Kyle.
All right. You know what? So for the past 6 months, my son is 6 months old now. I haven't managed all of it very well. And there also has not been too much sleeping. Fortunately, I have a wonderful wife that's very supportive, and she's really the reason why I'm ever able to accomplish anything, to be quite honest.
Okay, and how about you, Scott?
Well, at least with Kyle, I'm a little bit further ahead. I have a middle schooler and a high schooler, so I got caffeine to keep me going. And this week, it's still healthy for you.
As do we all. So I wanted to thank both of you for coming today. And we wanted to dive in to the topic of corrective exercise. And specifically, I'll ask you some questions about the inhibition and lengthen components of corrective exercise and how that impacts the well-being of exercisers and in general the activities of daily living of everyday people. So first, let's give our listeners a definition, a working definition of corrective exercise so that we're all on the same page as we go through this interview. And within NASM, we define corrective exercise as simply a systematic process of identifying the problem. And this is done by using various assessments. We try to train our corrective exercise specialists to identify the client's preferred movement strategy that they use to complete their specific activities, and we look for inefficient movement, however that's observed. We don't diagnose. Then we solve the problem using very targeted flexibility and strength training program design using our FourStep corrective process, and then we implement the solution using the same process. So Kyle, since you've been involved with corrective exercise in NASM for quite some time, 15 years, can you dive a little bit deeper into that process and how you use it with your clients.
Sure. And first of all, I think what you just described there is really deep enough. So if we look at that definition of being, the systematic process of identifying dysfunction and then designing a program and executing that program, that's really what we're trying to do. I really like that you mentioned inefficiencies in movement. And I think it's a very important thing for our listeners and our students to think about here is we're not diagnosing. We're not trying to say that our clients have problems. We're not trying to say that they're broken or dysfunctional. We're trying to improve their movement quality. And that's really what corrective exercise is all about. The word corrective, that's something that could be used just amongst professionals, and you don't have to tell your clients that that they're involved in a corrective exercise program. We're using a specific process, a specific strategy. We're trying to clean up or improve the efficiency of their movement so that way they can achieve their goals, whether it's a performance goal or it's just improved activities of daily living goal.
Okay, that's a great explanation. Now I want to follow up with you, Scott. You are in a unique position because you have a clinical process where you are actually diagnosing and treating injuries, and you work with your patients and clients at a little earlier step within the health and wellness continuum, and you take your athletes all the way through some aspects of physical training. So can you expand or add a little more detail to this definition of corrective exercise as you are using it presently?
Yeah, I mean, I think Prentice, the definition you gave and what Kyle expanded on really fits. But from a healthcare standpoint, if we diagnose and we have a client in the early stages who's injured, the corrective exercise continuum allows us to look at more so the mobility, stability, motor control deficits that we see in those early stages. And so the corrective exercise continuum allows us to, kind of begin to, if they have let's say an injured tissues or joints, the corrective exercise continuum allows us in the early stages to help restore those functional movement patterns that we always talk about, right? That movement efficiency. And so as the client progresses through the stages of rehabilitation, and once we start getting them towards transitioning them from rehabilitation to the gym or to a higher level fitness and stuff, the corrective exercise continuum that I find in my practice is continually being used at each stage in the rehabilitation process. Because, when you start introducing clients to new exercises, more advanced movements, more advanced triplanar movements, there needs to be some corrective, because a lot of times those clients need to continue to download that software, right, for the more advanced patterns and stuff. So I think the CEX really provides a good evidence-based process that can fit through the whole continuum of care.
Well, thank you. That's very impactful. That's going to be very good for our clients or our students to use as they're starting to implement corrective exercise within their training businesses. Now, within the industry, there are a few different perceptions about corrective exercise, and I'll let each of you chime in on this. Number one, that corrective exercise is for broken people only. What do you have to say about that, Kyle?
Most people are broken.
Yeah.
No, again, going back to looking at movement quality, unfortunately, we don't live in a society that promotes these optimal movement patterns. So we have to view each client through that lens and identify their movement limitations, and maybe they're able to still perform at a very high level. But in most cases, there's going to be, an ankle restriction, or, a hip movement and hip range of motion, or, thoracic spine that's not quite moving the right way, something there. We're going to use the assessment process to identify this, and we're just going to improve it. We're not going to prevent them from working out. We're not going to prevent them from doing the things they enjoy. We're just going to use this process, improve the way they move, and again, it's going to help them achieve their goals better. So we don't have to be broken in order to see the advantages of corrective exercise.
Okay, and what do you think about that, Scott?
And I agree with Kyle, is that, very simply, I think the corrective exercise continuum is for both healthy and injured individuals. Like, for example, if I'm working with a relatively healthy client and they're demonstrating an observable upper cross syndrome, I'm going to correct that before I do a lot of overhead activities to prevent any issues with the shoulder or the neck. So I think definitely, the corrective exercise continuum can apply to all clients. But again, we always go back to the individual and what they need. But the great thing about the model is it fits with most people that we see.
Okay, that's great. And I want to stick with you on this point, Scott, and ask a follow-up question. Now, in talking to some people who may come from different traditions, there's a perception that corrective exercise isn't necessary. All you need to do is just a good warm-up and then get after it. All of this is just a waste of time when the objective for a session is to, let's say, for example, just improve your strength. How would you respond to that?
Well, I think that there's a lot of very old traditions when it comes to even, with rehabilitation all the way through, strength training, strength and conditioning. And I think as we start appreciating the complexity of the whole myofascial system of how the body moves, we're beginning to really realize that, in order to prep the body for movement, we have to allow the client to download the software, right, through corrective exercise. And through corrective exercise, what Dr. Stoll alluded to is we're really trying to train proper movement. So the corrective exercise continuum could be simply teaching somebody how to do a single or double joint exercise properly, or it could be a more complex multi-joint movement, right? So I think when we look at the newer paradigms, we're really trying to help the client download the software for that proper movement through corrective exercise. And again, we're trying to get all the kinetic checkpoints, right, with any of the movements to function synergistically and efficiently. And I think that that's the key thing that I kind of follow in my practice.
Okay, great. Kyle, do you have a follow-up to that point?
Yeah, I love that. And then I would add that a corrective exercise program is just an intelligent warm-up. If the debate is that we just need a warm-up before we move on to these, whatever the other goals are with training, well, that's what the corrective process is. It's just a targeted warm-up. We're doing specific things to specific areas of the body, all based on the findings of the assessment. So it's not, it's going to be much more individualized and targeted versus just the traditional general warm-up.
Okay, great. And that's a perfect segue into the process. So let's unpack the four-step process. Can you both talk about the scientific rationale for each of the 4 steps of why it works, and then additionally, is there a consensus on the mechanisms at work, why they work the way they do? So let's start with Inhibit, and Kyle, since you literally wrote the book on foam rolling, why don't we start with you?
All right, and I wrote the book on foam rolling based on the research of Dr. Cheatham. But the So looking at inhibition, so we're essentially trying to calm down overactive tissues. Now, if you get into the science of it, and I'll let Scott speak a little bit more on this, but we're influencing or we're working with the nervous system. So we're using a foam roller to apply, or some sort of a device to apply pressure to tissues, and that's going to down regulate the tissue. And essentially, the goal is to improve joint movement. So we identify an issue that's going to be overactive or facilitated, if you will. We're using this. It's just one of many potential interventions that could be used to help inhibit a muscle that's doing too much. It's just something that we can teach our clients to do rather effectively. That's why we use foam rolling in this setting. But yeah, using it to apply pressure to it to downregulate the tissue, and the overall goal is just to improve joint movement, and we're using that on one side of the joint.
Okay, perfect. And Scott, do you have anything to add to that, to the science of inhibition and why it works?
Yeah, and I think for our students and our viewers and stuff, and everybody who's listening to the cast here, I think it's important to understand that traditionally we would use like manual massage techniques, right, to help kind of have some type of calming effect. But I think the science now, and what Kyle and I learned through our research, is that when the foam roller rolls over the tissue, it compresses the myofascia, right? So you start getting a compression of the myofascia. And that's similar to a lot of other tools that people use, allied health professionals, deep tissue massage or the tools and stuff. But one of the most efficient tools we found was the foam roller, because as the tissues, the muscle and the connective tissue gets compressed, that tends to have an inhibitory effect to kind of calm down, or in a sense, just plainly speaking, soften the tissues of the muscle. And so we know that a lot of our clients are having that pattern overload and those overactive muscles. So the best step in the continuum is to inhibit those overactive muscles that we see. And so scientifically, we're seeing that if you're rolling for a certain amount of time, tissues get relaxed, connective tissue, for phase 2 of the continuum. So personally in my practice, and also as a researcher, that using the foam roller is probably one of the most efficient, effective tools for the Fit Pro for that phase.
Okay, great. And before we continue, I want to remind all of the viewers to leave your questions in the Facebook comments section, because at the end, when we're finished asking specific questions to Kyle and Scott, we want to make sure that we get all of your questions answered. So please start putting those questions in the Facebook comments section. Okay, great. So I just have one follow-up question. You both mentioned downregulate the tissue. Is there any agreement on specific nervous system mechanism that's causing that, or is the jury still out? Let's start with you, Kyle.
I'm going to defer to Scott.
Okay.
There is consensus, I would say, if we start to look at some of the leading researchers on this field. I think everybody's kind of funneling themselves down the same path whenever it comes to this, if you want to call it nervous system regulation. But if Scott, if you don't mind going into that a little bit more.
No, thanks, Kyle. I think, yeah, so I think the research and the researchers is suggesting, right? It's suggesting that as you're rolling on the foam roller, you're stimulating a lot of the local mechanoreceptors in the skin, okay? The skin receptors. Also, you're affecting the muscle spindle and the GTO, which are those afferent receptors that send information up to the brain. So by rolling, you're creating, you're stimulating the brain, and you're creating almost a sense of like a disruption up into the central nervous system. And then that results in an efferent kind of the motor, the motor coming down, it results in a relaxation of the muscle through the stimulation of these receptors and stuff. And so what we're thinking, the current thought is there's two actions. One, mechanically, the roller digs into the tissues, so you're going to be kind of increasing blood flow and moving, fluids around within the myofascia. But also, though, too, you're stimulating those afferent receptors, so you're creating this form of kind of like this disruption or modulation of the central nervous system that results in this relaxation or stretch tolerance, per se, of the tissues. So that's kind of in a short, plainly talking, not too nerdy, hopefully, definition.
No, and I'm glad you answered my follow-up question for me, or you actually answered my follow-up question, and I just wanted to know if there were any localized tissue responses to that as well, regarding blood flow and things of that nature. So let's go ahead and talk about the science of lengthening and what's happening there, so that our students get an idea of why it's important to stretch before doing any activity. Let's start with you, Kyle.
So in our lengthening phase, we suggest a couple different types of stretching. We use static stretching most commonly, and again, kind of going to the foam rolling. One of the reasons we use static stretching is because it's safe, it's easy to teach your clients, and it's something that, if you spend the time to teach them correctly, they can repeat it on their own. And in order to get the benefits from any of this stuff, it has to be repeated, and it has to be repeated often. So static stretching is what you'll see taught quite often. However, we use neuromuscular stretching. You can also use active isolated stretching. Even dynamic mobility, dynamic stretching can work if it's integrated correctly. Whenever we look at lengthening, what we're trying to do is essentially work with the stretch reflex, right? So whenever we are, or stretch tolerant, stretch reflex. So whenever we put a muscle under a stretch, we're not literally stretching out those muscle fibers. We're just improving the ability of that muscle to move. So again, stretch tolerance, looking at the ability of the muscle to stretch. This feeds, or to looking at the extensibility of the muscle. This feeds off of foam rolling, because just like Scott said, that foam roller is going to kind of soften the tissues. It's going to get some of those tissues to moving, to sliding and gliding. And then we're going to take whichever muscle to the first point of tension, and we just hold that for a specified time. And again, we're just improving joint motion overall. We're going to target our flexibility or our lengthening techniques to the muscles that were identified as being short and overactive in our assessment process. So that's the reason we would move on to lengthening after foam rolling.
Okay, great, thank you. And speaking of lengthening, Scott, I'd like you to answer this question. I've heard at times that flexibility training may have, it may diminish the effects or the potential for strength and power-based activities. Now, how would you address that stretching?
Yeah, I think it's interesting, because there's, when we look at the last 5 years, maybe 10 years of research, just to kind of keep it simple, the early research was saying that if you statically stretch and kind of hold the muscle for a long time, you kind of soften it and you lose the tension. So that's going to drop performance. Okay. But now more recent research from one of our esteemed colleagues, Dr. David Bem, who was an amazing author in the CES, a lot of the more recent research is suggesting that static stretching may not have such a deleterious effect on performance. Okay. And so the current thought is that if you choose for your client to statically stretch before, let's say, activity, you may want to try and reactivate things through dynamic. So the combination of static stretching with a kind of dynamic mobility kind of activation again after you kind of theoretically lengthen the tissue tends to be kind of the best combination so far in the research. But it's interesting because the last couple of years, there's been a mixture of research that said, well, if you statically stretch before, it doesn't change performance that much. And then there's some research that says, well, static stretching does decrease performance. But when we really dig deeper and drill down to the research, we see that those studies are done on different sports, different populations, different age groups. So I think if we just kind of take the average of everything, we can kind of see that if the Fit Pro decides to kind of inhibit and lengthen before an activity, it might be good to do some dynamic kind of prep warm up immediately after to kind of re-energize or upregulate that nervous system. So that's kind of the current thought.
Which is definitely the idea in a strength training perspective, to not go for your work sets right at the outset of your session. You want to?
Can I add to that?
Yes, please.
So when Dr. Cheatham says, adding in a dynamic or, something else afterwards, you need to think of that as being the corrective exercise process. So we're performing static stretching, foam rolling, static stretching. We're not going right into lifting big weights. We still have our activation and our integration phases, and that's going to help get the nervous system back on the same page and ready for, a higher level activity. So that so it all kind of fits in with the overall model. And the other thing on that, most of the research, we need to understand that it decreases the performance, or to a large degree, decreases the performance of the muscle that was stretched too. So if we look at testing the strength of the hamstring and then statically stretching the hamstring and then retesting the strength of the hamstring, the strength is going to go down. However, if we were to look at maybe going through that process, but testing the strength of the quadricep or maybe a different muscle that is associated with the iliofemoral joint, we may see that muscle, the strength of the muscle actually goes up. So just something to consider.
Okay. Well, thank you for that. Let's finish up with the process. And Kyle, let's start with you. Let's just tackle activation and integration together. And I think we've alluded to it in going through the entire corrective exercise process before doing your more intense working sets for whatever activity that is. But why are activation and integration so important in the corrective exercise continuum?
Yeah, so we would use activation immediately after our lengthening. So the process is inhibit and lengthen. Think of those as being your mobility strategies, and those are going to be on the same muscle or the same group of muscles. And then our activation is typically going to occur on the other side of the joint, the muscle that is underactive. And activation exercises are typically going to be what I call low threshold. So they're easier for the clients to perform, meaning that we would, for example, put somebody flat on the ground. So that way they're not also having to worry about stabilizing against gravity. They'd be flat on the ground and then going through something like activating their intrinsic core or glute activation or something from a sort of an easier position, if you will. And we use that here to upregulate those tissues. So we downregulated the tissues on one side of the joint. Here we're going to try to activate or upregulate the tissues on the other side of the joint. The overall goal is to create that balance around the joint. So trying to get all of the muscles to doing their respective jobs and get everybody on the same page. Now going from there right into the integration, we just working on things in isolation, right? So if we just stretch or if we just activated, that doesn't mean that the nervous system has truly learned what to do with that new information. So integration is going to be looking at the overall pattern. So we're going to integrate exercises that that are typically functional in nature, to where we're replicating activities of daily living or something along those lines. And we're just putting everything together. We're teaching the body what to do with those muscles that we've lengthened and what to do with the muscles that we've activated. So it's just sort of saving or setting that pattern, if you will.
Okay, great. Thank you for that. Thank you for that definition. And let me ask you a follow-up question, Scott. So, for athletes you work with who don't have apparent movement compensations, like a sedentary office worker, for example, and you mentioned software a lot. How do you use corrective exercise at higher levels of performance?
Well, thanks, Prentice. I think a great example is I have I've been working with one of my recent clients is a football lineman, and we found he had suffered an ankle sprain during a game, but we found that he had decreased mobility in his ankle, so that is overhead squat. So a lot of the things, once he was cleared for more of the later phases, we put I ran him through the first 2 phases of exercise continuum. We did a lot of, mobility stuff. So Inhibit and then Lengthen, we were able to get his ankle to be more mobile. And then when we went to activation, I immediately went back to the overhead squat, and I put him in front of a mirror so that he could actually have the visual representation. And then we loaded him with his body weight, and then so that he could see any compensations and stuff. And then once he demonstrated, appropriate movement at each kinetic checkpoint, then we moved forward and we started loading him with squats. And we started loading him with the bar squats and stuff. And so that's kind of more recently how I've been able to apply the corrective exercise continuum to like an athlete, where, once we regain that mobility, kind of extensibility of the tissues, then I try to activate it into a full range of motion. And then I try to integrate it by loading the nervous system and loading the whole myofascial system.
Great, thank you. And Kyle, do you have any examples of that process?
It would be with an athlete or with any
With an athlete,
particular...
sure.
Looking at overhead athletes' range of motion, so restricted motion in the shoulder, and actually going back to something Scott mentioned earlier, talking about using the corrective exercise process for people that aren't broken. We need to learn to use this as a tool for identifying potential risk factors. So looking at an overhead athlete that's demonstrating that upper cross, they may not have shoulder pain yet, but as a fitness professional, as a corrective exercise specialist, we need to do what we can to try to prevent that. So then we would integrate and implement these strategies, looking at what may be the limiting factor in shoulder range of motion, and doing our best to improve it. Of course, if we're dealing with an elite level pitcher or somebody like that, we may not want to deal with the range of motion in his or her shoulder, just depending on if they need that for whatever their level of performance is.
Sure. Okay, so now speaking about general population, and these are all excellent explanations, and I'm happy that you both are here today. But how do you convince the fitness professional across multiple specialties, whether they train with seniors or athletes or anyone in between, that this process, this corrective exercise process, is number one, beneficial, and that it's to their client's advantage that they follow this process through its entirety, through the 4 steps? How do you convince a fitness professional? Let's start with you, Kyle, since you're probably mid-semester now, and you're having to convince young athletic trainers that They need to use a similar process like this.
Yeah. So obviously in the accelerated program that I teach in, we're almost to the end. So a couple of weeks ago, it was trying to convince people to use it. One of the best tools, a couple different ways. First of all, this is something most people are already doing. We're just applying a little bit more of a process to their warm up. So going back to what we said earlier, this is an intelligent warm up. You're already warming up. Let's, however you're doing it, let's make sure that your warm up is individualized and targeted to the person based on their movement patterns. So that's going to be looking at things like foam rolling. It's become so popular. I don't feel like that's much of the argument anymore. But instead of just doing an arbitrary rolling session, let's roll the areas that actually need it. It's going to save your client time. It's going to save them money in the long run. So again, just targeting things they're already doing. The other thing is that this isn't new. The National Academy of Sports Medicine, in my opinion, has laid out the best process, but it's not the only corrective exercise process. So we can look and see that lots of credible organizations are doing similar things. We're looking at mobility, we're looking at activation, and then looking at patterning. So it's not just some sort of a one-off. It's rooted in science. It's an individualized warm up, and other very intelligent people are using it.
Exactly. Scott, do you have anything to add to that?
Well, I mean, I think Kyle said it perfectly that, and I think to add to that, though, I think too, we're seeing a convergence of, our clients really understanding the need for some type of corrective. I mean, we, for the new rollout of the whole CES material, we had so many great experts and authors writing about it. The biggest thing I gleaned from kind of reviewing and working with all these great people is we're seeing from all different professions that the need for corrective exercise and pattern overload and how society is with cell phones and all that, we're seeing this big need for corrective exercise. And so I think on a whole, we're seeing clients and professionals starting to see the same thing, that we need to address all these patterns and all this dysfunction that comes with posture and the way of life that just takes us at work, at home, or driving. And so I think on that note, I think that the CEX provides a good evidence-based template. And again, yeah, we're not the only one who's doing it, but I think when I teach it to my graduate students and I look at that, they find that it fits anywhere in between anybody's periodization program, anybody's training, where corrective exercise is needed. So that's where I see it.
Okay, great. And Kyle, I want to go back to you because you brought up something. You made a very good point in that doing targeted flexibility and strength training as a warm-up actually saves your client time. How do you address the fitness professional who has gone through our text, taken the workshop, and they feel just completely overwhelmed with putting everything in its appropriate place? Identifying overactive, underactive muscles, and then taking their client through that entire process. Is there something that you can offer to help a fitness professional streamline that, to really give them the value of using this process?
It is just like anything, it's a skill that is learned with repetition. So the more you use the system, the more you apply the system, you're going to become more efficient. It's going to get quicker. It's not always going to be overwhelming. Whenever it comes to looking at the FourStep model and the exercise execution, or if we just say, I guess, program design application, Don't try to do too much at once. All too often we will see the new corrective exercise specialist that has a list of 30 muscles that they need to try to foam roll and stretch, and then we have 15 that we need to try to activate, and then 17 different integration exercises. We need to use the assessment process that's been laid out in this new edition of the text and make sure we're identifying the 1 to 2 most problematic muscles, or a group of muscles, and then just going after those. Like, that's the beauty of learning the corrective exercise process, is we're identifying the most problematic area and targeting our strategies towards that. So it's short and sweet. A corrective exercise program should last 10 to 15 minutes. Now, of course, if you wanted to do a longer program, you could add more to it and make it 60 minutes. But think of this as being, like we said, intelligent warm up, 10 to 15 minutes, roll a few areas, stretch those areas, activate 1 to 2 muscles, 1 integration exercise, and then you're ready to go.
Okay, great. Thank you for those explanations. This is my last question, and this is sort of a grab bag question. Both of you gentlemen are well traveled. You impact a lot of people. You teach a lot of students. Are there any myths that you'd like to dispel for any part of the continuum? The rationale for corrective exercise? Is there anything that you've heard that you'd like to dispel right now for our listeners? Let's start with you, Scott.
I think sometimes when I'm teaching the material to my students, I think they're concerned with age, and I think for most of the populations we deal with, the corrective exercise can be for all ages. Within the working out within the gym setting or whatever. So your middle schoolers all the way up to high schoolers, all the way up to older adults. I think that the corrective exercise model fits all age groups, because I've overwhelmingly heard from my students that they're concerned with the different age groups, and I think that whatever the client fails on during their assessment or score low on, that's going to be the person's homework. That's how I teach it, right? So, and I think that can be for all age groups. So, if you're working with an older individual and their goal is to garden, well, your program is going to be around corrective exercise to help them garden. If you have the athlete, it'll be more sport specific. So I think the corrective exercise can fit into all types of people and along that continuum, but it should just be one part of a complex strategy, right? Including strength training, cardiovascular, addressing all aspects of performance, because we want each of our clients to be physiological ready for any goals that they have. So I think one of the biggest myths is that the corrective exercise is not appropriate for everybody. Unless there's a big red flag or a big medical issue, I think the corrective exercise can be used for most people that we work with. And again, pending any type of serious medical issues or something like that, I think it has a lot of utility, and that's my take.
Okay, and Kyle, do you have anything to add to that?
Yeah, so another one that I hear quite a bit is that since the body works as an integrated unit and we work with muscle synergies and functional force couples, we shouldn't be trying to chop it up into individual body parts through a corrective program, or really through any process, or to state that differently, since the nervous system doesn't work by thinking about glute med activation, then why are we trying to teach glute med activation exercises? And my response to that is that we need to divide it up into the basics in order to reach an overall goal. So if we're looking at learning how to hit a ball with a baseball bat, we wouldn't get out there and just start swinging and hopefully one day we make contact. the first thing we would have to do is go all the way back to the basics and learn the stance. If you're not standing right, you're not going to be able to swing right. So you spend time learning the stance, then you spend time learning how to grip the bat, then you spend time on all of these individual segments for that overall end goal of making contact with the ball. So we have to break this down into these individual segments to get everything primed and everything ready. But we then move on to that, putting everything together with the end goal of improving performance or improving whatever it is, the person's goals are. I'm not sure if that makes sense.
That makes perfect sense to me. I'm sure we'll get some feedback from our audience if they have additional questions. And speaking of audience questions, this first one is for you, Kyle. Can you discuss the difference between the pin and hold technique, oscillatory technique, and using a tool like the hypervolt, vibration or percussive tools?
So the difference, I'm assuming that talking about if they have a different effect or a different overall impact. And I can't tell you that I don't know if they have a different impact whenever you apply them. Whenever we look at pin and hold, we think of that as trying to increase, improve the ability of those muscles to slide. So we're using the roller to pin down tissue, and then we're activating a muscle to help pull the pin down tissue through there. So it's similar to wringing out a towel. And the idea is that we get that, better lengthening of the muscle whenever we do that. Whenever we start looking at an oscillatory technique, I'm going to assume let's say this is my roller. If you put your leg or something on top of it and kind of move side to side, that again we use it as kind of like a cross friction. The thought is that we're moving across those muscle fibers. Again, same goal. We're just trying to get better movement, better sliding in between those tissues. Whenever we move to something like a hypervolt or vibration technology, I think it has a similar effect to where we're putting the vibration on there and it's moving the tissues. However, we do see in our research that seems to be a bit more, it stimulates some of those mechanoreceptors and those pain receptors a little bit differently. So in Scott and I's research, that vibration really helped to decrease the pain pressure threshold. So we were able to kind of turn down the volume on pain by using that vibration.
Okay, great. Thank you for that. Before I go on, Scott, do you have anything to add to that?
Well, no, I think Kyle said it. I think Kyle said it perfectly. I think the vibration in like a foam roller, I think it's great for the audience just to realize that it's local vibration and not to mix it up with whole body vibration like the power plates that are popular in the gym. I think that's important to understand. Also, too, the newer mechanical percussion guns out there, like the Theragun or the Hypervolt. Unfortunately, right now there's no research on that, but researchers and stuff and clinicians were thinking that it has a similar effect, that it's compressing the tissue and causing that vibration from that. So I think we're going to start seeing over the next couple of years that the research is going to start showing up similar patterns among all these devices as far as effects.
Great, thank you. Okay, and I'll stay with you, Scott. Next question, what are, if any, the considerations for foam rolling during pregnancy?
Okay, I think that's an important one because so far the general precautions, pregnancy is considered a precaution, but it's also considered a contraindication. So that's going to be very individual specific on that. And so I recommend if the fitness professional has a client who is pregnant, you need to check with their OB/GYN doctor and just to get some clarification. One of the concerns in general is throughout pregnancy, we understand that physiologically the body is going to be having heightened, and they're going to be going through ebbs and flows of these hormone changes, and so that can loosen up ligaments in the sacrum, low back, kind of in the area. So there's some general relative precautions: is end range stretching, even foam rolling, like the low back, the hips, the sacrum, and stuff like that, are considered very, very precautionary, but almost contraindicative. So far, the general consensus is that it should be individual, but I do recommend that the fitness professional proceed with caution on that, and get some clarification from the doctor. That's just my opinion.
Okay. Kyle, do you have any additional comments regarding that question?
Definitely agree. First thing you need to do, or anytime you're in doubt, make sure you refer out or speak to the physician. The other one, pressure points in the lower leg that have been known to induce uterine contractions. So especially in the third trimester. So those are some of the reasons why it's a precaution. At the end of the day, one of the things everybody needs to realize is that while foam rolling is an excellent modality, you don't have to do it. It's okay if your client's not comfortable rolling for whatever reason. It's not going to mean that the corrective exercise process is all of a sudden ineffective. It's still effective. So it's a good modality, but if for some reason you can't do it, it's okay. Move on with the other 3 steps.
Okay, perfect. Let's go back to you, Scott. And what are the effects of foam rolling on neurodegenerative diseases like Parkinson's? Is it ever contraindicated in that population?
Well, I think that's a great question, because a lot of the demyelinating or neurodegenerative diseases and stuff, that's coming from the central nervous system. So there hasn't been a ton of research. Maybe Kyle will be able to understand, be able to comment a little bit more too, is that there hasn't really been a lot of research in this population. So it's really hard to comment on, if someone has this Parkinsonian gait where they're just doing the shuffling gait, or, from that's more from the dopaminergic pathways, which is more in the central nervous system. So foam rolling and stuff like that, we don't know yet if there's going to have a huge effect on trying to restore those motor patterns that are often seen with the Parkinsons and stuff. So far there's been a couple researchers who are trying it. They're getting some anecdotal evidence, but it's very short term. So it seems like that the central nervous system that's kind of affected with Parkinson's tends to reset quickly after that, because you can also look at the massage research with Parkinsonians and stuff, and a lot of it is very, very short-lived. So,
Okay.
So far, I have no really true comment, just kind of looking at it right now.
Okay, great. Kyle, do you have anything to add to that discussion?
The same regarding the research. I'm not aware of any published research that's out there. But then turning to anecdotal, one of our colleagues that works with Parkinson's patients, he has excellent results using a vibrating foam roller. But again, anecdotal. I don't know how long the results last. It's just something he uses regularly with his clients and seems to get great results with it. So I think it would be worth trying. We definitely wouldn't want to do any sort of deep or aggressive rolling, but if you had a vibrating foam roller, just seeing what the short-term responses are, and if it works well for you and your clients.
Okay, great. Have 2 more questions. This next one is it's a lot to unpack, but I will stay with you, Kyle. Is there any concern compressing the lymphatic system as you're compressing on the myofascial tissue? And if so, how do you ensure the lymphatic system is not being compromised? And are there any areas you suggest you don't foam roll?
So regarding the lymphatic system, anytime we roll, you compress everything that's in between the roller and the bone. So yes, we are compressing the nerves, we're compressing the all the vascular tissue, we're compressing the lymphatic, so we're compressing everything there. Now, as far as damage goes, I will have to say I don't know of any cases where anyone has there's been any damage to the lymphatic tissue. So not saying that it hasn't happened or it can't happen, just to my knowledge, I'm not aware of any. And then looking at just areas to avoid foam rolling in general, not necessarily specific to the lymphatic system. The sensitive areas we call, around the groin, of course, we have the inguinal, right around the inguinal triangle where there's, direct access to vessels and such. We want to be careful. We want to be careful up around the armpit, jamming things in there. Be considered a sensitive area. Anytime you need to do stuff around the neck, I don't recommend really using any tools for areas around the neck, not for the average client anyway. And I think those are the main areas. The abdominal region, of course, we want to be very careful sticking very large, hard things into anything there. General rule of thumb is if you feel a heartbeat or a zinging pain or tingling pains or anything there, to just move off of it and roll a different spot.
Okay, great. Thank you. And Scott, do you have anything to add to that?
I think Dr. Stoll's comments on the lymphatic is right on. I think whenever you compress tissue, I think you're going to be affecting, all the vascular structures. I think it's important to be extra cautious when you're working with somebody who's had a compromised lymphatic system, like if they're like a post-cancer patient who's had surgery or something like that. I think that's very important because a lot of times they do from the treatments, the radiation and stuff, they can get adhesions and scar tissue. And so one of the things I know, a lot of health professionals try to do is they try to do a lot of myofascial release with that. And so I know that we have to be careful in those areas. The second thing too is I think just to add to the areas to kind of avoid would be also just bony prominences. Going over the greater trochanter of the hip. The sacrum and low back are just kind of precautionary too. You need to be careful going over bones with rollers and stuff. Those are just general precautions.
Okay,
And
thank you for that.
one other thing if I could add, we need to sort of get away from, whenever it comes to rolling, get away from the no pain, no gain type of a mindset. Foam rolling doesn't have to hurt. We don't have to, our clients don't need to be in tears. They don't need to break out and stress sweats. So if you have any sort of concerns, or really with all your clients, start really, really easy. Find the softest roller you can get and start there. That's going to be better than nothing. And if the client wants something a little more dense, if that's their preference, then you could eventually move to that. Because I think a lot of things like this question here stem from people taking the really hard objects and just jamming them into places where they shouldn't. Start easy and progress slowly.
Okay, and that's a good segue into the last question, which is for you, Kyle. Is there a recommended duration for the foam roll routine?
So in the research that Scott has done, he's done a couple of wonderful surveys looking at foam rolling duration, and we know the most recommended durations. So, usually looking at a muscle group, or a specific muscle, the recommendation is somewhere between 90 to 120 seconds. We start to see some decreases in performance over that 2-minute mark. So that's typically the recommendation. Looking at a total body rolling program, it's usually somewhere between about 10 to 15 minutes. However, we've not necessarily found and Scott, correct me correct me if I'm wrong, but we've not necessarily found a specific dose response type of a relationship to where 60 seconds spent on a muscle is going to give you this exact response versus 120 seconds is going to give you this exact response. We just recommend that range, working typically throughout that range. Two-step approach that we recommend in the textbook. We want to find a tender spot and hold it just to kind of breathe and relax. And then after that, we want to go through some movements to get some tissue to move through there. Usually takes about 2 minutes.
Okay, great. Thank you for those recommendations. Finally, Scott, do you have anything to add to that?
Well, I think kind of going back to the last two questions. I think Kyle said it right. Is when we're with our clients and stuff, we found even in our research that a soft, medium, or hard foam roller affects the central nervous system the same way. It's so sensitive, the nervous system. So I think it's great to start off with a nice soft roller and then progress as tolerated. We also looked at using a pain scale from 0 to 10 to kind of help guide the client. So you guys can, so I think the average, client can be progressed, just going from soft, medium, hard, just for more comfort, because we know that the mechanical and neurophysiological effects are often changed with just very little pressure. So we don't have to kill the client, right? And I think that that's a huge thing. And then on to the second question, I think it's important it's kind of weird in all the research and in our research, if we roll on a muscle group, like 2 minutes or over, somehow that kind of flips a switch. We're thinking that maybe the body starts to become a little bit more parasympathetic or some type of relaxation. So we want to keep that, kind of like that, 2 minutes or less kind of thing, if we're looking just to kind of stimulate the tissues, get more stretch tolerance, get more mobility. But if we're looking to really just do a deep relaxation massage, us and other researchers, we're suggesting to go longer, just to go for a longer duration and try to just roll it out and get the client to relax and kind of be mindful and stuff and turn it in there. So I think that there's a place for inhibition before and after exercise.
Okay, great. Thank you very much for that explanation, and I want to thank both of you gentlemen for joining us today and sharing your knowledge with us. It was very informative as always, and I always feel a little bit smarter every time I spend time in the same room with you guys.
Thank you, Prentice, and I want to thank NASM for it.
Yes, and as a gift for those of you who were on the webinar today, you can save 35% on NASM's Corrective Exercise Specialization. Use the code webinar18, that's webinar18, and this is valid only for today. So you'll call 888-773-1827 for more information. That's 888-773-1827. I want to thank all of you who stayed on with us for the entire hour, for your time, and I hope this was informative, and I look forward to seeing some of you in the future. Have a great rest of your day. Thank you.